Welcome, everyone. Thank you for joining us for a two-part webinar on calculated globulins, clinical and lab perspectives. I am Martine Pergent. I am the president of IPOPI, and it is my great pleasure to be your moderator today. IPOPI is the International Patient Organization for Primary Immunodeficiencies, and medical education about these conditions is one of our most important jobs. Before we begin, I would like to take a moment to thank CSL Behring for making this learning opportunity possible. Thank you. Today, we will welcome two guest speakers. Professor Antônio Condino-Neto from Brazil. You are currently Professor of Experimental Medicine at Institute of Biomedical Sciences at the University of São Paulo, Brazil. Your main research activities include the investigation of immunopathological mechanisms related to phagocytes, respiratory burst functions disorders, and the resultant susceptibility to intracellular pathogen infections. Your recent studies bring new insight to chronic granulomatous disease, hyper-IgM syndrome, APSED, MSMD, and tropical diseases. You will talk to us on the clinical aspects related to the latest research in pediatrics in low middle-income countries using calculated globulins. Thank you for being there. Professor Stephen Holding from the UK, you are consultant clinical scientist in immunology at Hull University, teaching hospital NHS Trust and honorary professor at Hull York Medical School. You have shown a long-established interest in the design of testing algorithms and screening programs. This includes the use of historical patient data to identify ways of optimizing testing algorithms to improve patient outcomes. You will talk to us on the laboratory technical parts of using calculated globulins. Welcome, professors. The full bios are being posted in the chat. After your presentation, 10 minutes Q&A will follow. Please, do use the chat to let us know where you are joining us from. We want this to be an interactive session, so please feel free to say hello. And do use the question tab, which you can find on the right-hand side of your screen, to ask questions at any time during the presentation and during the Q&A. Without further delay, we will start this webinar with our first guest speaker, Professor Condino-Neto. The screen is yours.
Hello. I would like to thank IPOPI. It's a great pleasure to be here with Martine Pergent and Professor Holding to talk about the correlation of plasma proteins and the immunoglobulin levels. We have recently developed research on this topic in children and adolescents, and I will be very happy to share our results with you and prompt for the next steps of this research. So the delay in diagnosis of primary immunodeficiencies leads to clinical complications and sequelae, prompting the need to develop screening tools to anticipate the diagnosis of those diseases, particularly antibody defects, the most frequent conditions. For this research, we aimed to investigate in plasma of children and adolescents the correlation between electrophoretically determined plasma globulin fraction, gamma, and IgG levels, and the calculated globulin and IgG levels. This kind of exam is very often ordered in clinical practice for several conditions in patients in intensive care unit, or even for outpatients, for those who will present with liver diseases, renal diseases, and any other metabolic, or for nutrition evaluations. So there are so many applications in medicine. And what we will discuss here is how to use this simple and very low cost laboratory tool in order to prompt further investigation of antibody defects, the most frequent condition regarding immunodeficiencies. We have studied a group of pediatric patients from 0 until 18 years of age. It was a total of 1,215 patients, which we classified in age ranges from 1 to 5 months, 6 to 11 months, 1 to 4 years, 4 to 10 years, and 10 to 18 years. And then we calculated the calculated globulin and correlated with IgG levels. Yeah? And the distribution of patients was more or less 50% males and 50% females, and all patients were on a stable condition. Here is the correlation curve. So we observed a very high correlation between calculated globulin and IgG levels in all age groups. So showing that this may be a very useful tool for screening antibody defects. Here is the area under the curve, confidence interval, sensitivity and specificity for the diagnosis of low IgG levels screened by calculated globulin. For the first year of life, it's actually difficult to establish a diagnosis of antibody defects because in this age, there is a strong interference of the maternal antibodies that are transferred by the placenta, and the child, there are many of them that still has to catch on the antibody synthesis. However, after the first year of life until adolescence, we see a very good specificity and sensitivity using calculated globulin versus IgG levels. So it is very useful to use those cutoff values that will be around 23 or 24 grams per liter calculated globulin. We further analyzed the direct gamma globulin correlation with IgG levels. As we use the plasma electrophoresis, we have the design, all of the curve of plasma proteins. So we had the direct gamma determination using this lab test. And again, we studied the same group of patients, and we have even a stronger correlation in all age groups, direct gamma globulin plasma with IgG levels. And when we calculate area under the curve, confidence interval, sensitivity, and specificity, we have even stronger correlations, prompting us, showing that this is a very useful and powerful tool to screen antibody defects. So the gamma globulin cutoff values will certainly change during the age. Why? Because as the child develops and get older, more mature, the child will produce more antibodies. So the gamma globulin fraction will be higher, as well as the IgG levels will be higher. But we had a very strong correlation, and it's a very powerful tool. So in conclusion, calculated globulin and electrophoretically determined plasma gamma globulin correlate with plasma immunoglobulin IgG levels in children and adolescents. calculated globulin and gamma globulin are potential useful tools for screening antibody deficiencies. We are keen to continue this research, interacting with big diagnostic labs in order to prompt our colleagues from biochemistry to give a kind of alerts to further investigate the patients that can be detected using this tool. So I would like to thank IPOPI for this opportunity. Here is my email, and I'll be very happy to answer questions about our research. Thank you.
Thank you very much, Professor Condino-Neto. And I think that you have setting the scene about the fact that this useful tool can help patients to be diagnosed, especially patients with antibody deficiency, of course. So now we will have the screen for the lab perspective, focusing on all age groups. And Professor Holding, the screen is yours.
Thank you. Okay. Well, I'd like to thank the organisers for inviting me to come and talk to you today about a subject that's very close to my heart, and that is how we use routine lab tests to do something about the problem of diagnostic delay in these patients with antibody deficiency. So I have no conflicts of interest to declare. So what I want to do today is talk a little bit about the problem with diagnostic delay in immunodeficiency, and talk particularly about how we use calculated globulins to reduce diagnostic delay in patients with antibody deficiency. And I'll talk a little bit about the evidence around how you choose a cutoff for calculated globulins, and how we've developed a strategy for patient testing, which has shown to, has been very productive in terms of reducing diagnostic delay in our patients and identifying patients with unsuspected antibody deficiency. So diagnostic delay is a very well identified problem in primary immunodeficiency. And you can see here that for CVID, which is the disorder we most generally talk about when we talk about antibody deficiency, that diagnostic delay is typically 2 to 4 years. And in this older data, it's more like 5 or 6 years. And this is actually age dependent as well, so that you see in this graph that this table that it's much more likely that immunodeficiency will be considered in children, and so diagnostic delay is typically much longer in adults. So you can see here that in children under the age of 16, the median diagnostic delay for diagnosis of CVID was 2 years, and that rose to 3 years in the 17 to 29 age group. And for the age group over 30 years, that was actually 8 years. And we know this is because immunodeficiency is not considered when these patients present. And that's the primary problem, that immunodeficiency is not considered. And we know that diagnostic delay is important because we know that once a diagnosis is established for CVID, for instance, immunoglobulin replacement therapy will reduce the number of infections and ultimately reduce end organ damage, so that we should see less bronchiectasis and other complications of those recurrent infections. So a number of ways that we can try and reduce diagnostic delay, and these have all been tried in different forms. Raising awareness of immunodeficiency and the clinical presentations is something that we've tried for many, many years, and there are many nice algorithms. For instance, this published by, sorry, I've lost my screen. There we are, thank you. Raises awareness of the signs and symptoms of primary antibody deficiency, and but it requires that the doctor considers antibody deficiency. And I think actually the main problem is failure to recognize that your patient might have antibody deficiency. Another option is to introduce systematic screening at set ages, and that works quite well for things like severe combined immunodeficiency and other genetic diseases, because they present early and it's a genetic disease, and if you screen, you can detect most cases. But for disorders like CVID, which can present at any age, that would require screening every few years, and that presents much more difficult logistical challenges. So then the other possibility is to do more opportunistic screening, because these patients with immunodeficiencies are presenting with recurrent infections, and indeed they'll present to healthcare services for all sorts of other unrelated issues. And these are opportunities to pick up on issues that might point towards immunodeficiency. And they're often having multiple blood tests done, and those blood tests often have clues to the presence of immunodeficiency, but are maybe poorly recognized. And we've written a nice review article, I think, in 2015, which goes through some of these routine blood tests that may be useful in early identification of unsuspected immunodeficiency. So I want to talk about calculated globulins in particular now. And you're very familiar with this, I know, and Professor Condino's very eloquently described the issues around correlation and so on with IgG. So calculated globulin makes up about, immunoglobulin makes up about 30% of the calculated globulin. So that I'm sure you're all familiar with this electrophoretogram of a serum protein electrophoresis, in which the gamma globulins on the right-hand side of the curve are where the immunoglobulins lie, and they're about 30% of that non-albumin protein fraction. And this really just confirms the lovely data that you've just seen from Professor Condino, showing the strong correlation between IgG level and calculated globulins. So this had a correlation R squared of 73%. So that means that 73% of the calculated globulin, of the variability in calculated globulin, is due to IgG level, which suggests that calculated globulin will be a very good screen for IgG deficiency and antibody deficiency. So back in 2007, we thought we'd take a look at some of our historical or recently diagnosed patients with CVID and see whether using calculated globulin might have reduced diagnostic delay for them. So we took the last 8 patients diagnosed with CVID, looked back at their medical histories and their total proteins and albumins, and it was evident that 5 of these patients had a clear delay in their diagnosis. They had clinical symptoms of recurrent infections several years before diagnosis. And this was, on average, was 4 years, but varied from 2 years to, for one poor patient, 30 years of recurrent infections before she was diagnosed. And when we looked back at those historical calculated globulins, we could see that if those had been acted on or reported and acted upon when they were first seen, that would have reduced diagnostic delay for 5 of those patients by an average of 3.5 years. So it was clearly something that was worth looking at in more detail. So we introduced a prospective testing program in March of 2007. And then over the following 5 years, any patient with a calculated globulin that was below the 0.5 percentile that we'd found in patients in samples coming from primary care, we reviewed those results and added immunoglobulin test on if we felt that there was an indication on the basis of the information that we had before us. So over those 5 years, we did nearly 3 million of these tests, and we did, and just under 1% of patients had a calculated globulin below that cutoff. And a selection of those, only 3% of them went on to have immunoglobulins, but you can see here that 80 of those 933 patients had an IgG of less than 3 grams per litre. So that meant we had a positive predictive value of about 8.6%. So for the patients that we thought needed immunoglobulins doing, 8.6% of them had an IgG of less than 3 grams per litre. And amongst all those, of the 186 patients who had an IgG below 4, we found 12 new unsuspected patients with CVID. So that's about a new patient every 6 months in a population of about 600,000 that we cover. And that still is true, that we continue to do this, and about once we see a new patient about once every 6 to 9 months. And in addition to those patients with CVID, we found 6 patients with unsuspected antibody deficiency for a variety of secondary causes due to treatment with rituximab, cyclophosphamide, and so on. But also we found 10 new hematological disorders, and disorders that are often difficult to identify. So a case of AL amyloid, 2 oligosecretory multiple myeloma, and 3 light chain disease as well. So these often present with normal normal serum protein electrophoresis. But so these are significant findings. So in order to use calculated globulins, though, of course, you need to decide on a cutoff. And we had originally taken all of our calculated globulins and chosen the first percentile. But of course, all our calculated globulins from our patients include a real mix of different types of patients. So we wanted to try and standardize that a bit more. So what we do now is, in fact, we choose a cutoff that identifies 0.5% of patients from primary care as having low calculated globulin. It's really important to realize that actually there's quite significant variability between labs, even labs using the same method. So you shouldn't really take somebody else's calculated globulin cutoff in grams per litre and introduce it in your lab. You really need to look at your local data and choose a cutoff based on a percentile of a set group. And primary care, we found, is a really good, reliable group that produces consistent results over many years. It's also important, of course, to consider the effect of age, which I'll come to in a minute. And then differences between the different patient groups. Do you use the same cutoff for primary care, outpatients, inpatients, antenatal? Do you even test these patients? But I'll come to that in a minute. And then when do you repeat the immunoglobulins? If a patient has had normal immunoglobulins 12 months or 2 years ago, and they come in with a low calculated globulin, do you repeat the immunoglobulins? I'll answer that question too. So this just shows you the distribution of calculated globulins in our primary care community of patients. And you can see that it's a nice log normal distribution. And if we just look at the bottom end of this curve, this is now a cumulative distribution curve. So you can see that we just report in whole units. So we report albumin and total protein in grams per litre in whole units only. And so you can see here that with every increase in calculated globulin of 1 gram for a cutoff, the number of patients that are positive more or less doubles. So if we describe patients as less than 22 for a calculated globulin as being positive, then that will be about 0.2% of patients. And if we move that up to 23, we'd be actually trebling. It's close to doubling, actually. It's just a rounding effect that you're seeing there. And again, if we moved it up to 24. So the cutoff we're actually using at the moment is 23, because we aim to identify 0.6% of patients as being positive, and to have calculated and to have immunoglobulins performed. So you can see that the cutoff that you use in the left-hand column here. So we've chosen a cutoff based on primary care results, and you can see that, for instance, if we use a cutoff of 0.5%, then that would of course result in 0.5% of all primary care patients being positive, but 1.5% of all patients overall. And that's because we have a lot of inpatients coming through the department as well. and they typically, a lot of those are post-op or on infusions of some sort, which is causing dilution of the immunoglobulins. And then with our cutoff of 0.5, we believe that has a sensitivity of somewhere in the region of 60 to 70% for a very low IgG, and has a positive predictive value of about 8 or 9%. You have to choose an age cutoff as well, of course. Now this just shows the percent of patients that fall below 1%, our overall 1% cutoff for all patients. Now this is contaminated by the patients in the who are inpatients on the wards. So, but by the age of about 9, the curve is fairly flat, and so in fact that's the age cutoff that we use. So we only use calculated globulins in patients from the age of 9. But I think actually that's a problem with our data, rather than that it's not appropriate to do it for smaller children. I was very interested in the data shown in the previous presentation, that I think we need to look at primary care results for that age group to see whether actually we could take that age lower, because clearly many patients will present at an earlier age. So who do you apply calculated globulin screen to? Well, we apply it to all primary care, and indeed we use primary care, as I said, to determine our 0.5% cutoff. And we automatically reflex test to immunoglobulins for any patient who hasn't had an immunoglobulin done in the previous 6 months, if they fall below our cutoff. And we use the same format for outpatients as well. So we would reflex test to immunoglobulins if they fall below that cutoff. Now, originally, we didn't include oncology and hematology because we felt that they would be aware of the issue around secondary hypogammaglobulinemia. But it transpires that actually this is quite useful, because even amongst this group, there's often unsuspected hypogammaglobulinemia. And we exclude our renal transplant patients after discussion with our renal department. They specifically asked that we don't report this for those. But we do include all other immunosuppressed patients. So patients attending rheumatology, for instance, or with other inflammatory diseases that are on immunosuppression. And then for inpatients, we use the same cutoff as we use for primary care, but we don't automatically reflex test to immunoglobulins. We instead refer those to an immunologist for review, refer the results to an immunologist for review. And for most of them, they're just post-op samples in which it would be inappropriate to do immunoglobulins. But one important group are the antenatal patients. The antenatal patients have a different cutoff. Because during pregnancy, there's an expansion of the plasma volume, and the calculated globulin cutoff therefore changes. So we actually use a cutoff that's 2 grams higher than the cutoff we use for everybody else. And when is it necessary to repeat the immunoglobulins? Well, this shows a sequential calculations of calculated globulin in a single patient. Excuse me. This shows a single patient with sequential calculated globulins over a period of several years. And you can see that the calculated globulin was normal about 24 months before diagnosis, and then it fell quite rapidly over about 12 months. And when we look at historic results on patients before diagnosis, we find this pattern is fairly reproducible, that the IgG seems to fall over a period of about 9 to 18 months. And that's why we use a 6-month cutoff for repeating immunoglobulins. So it's quite clear to me that calculated globulins have a really important role in achieving earlier diagnosis of hypogammaglobulinemia. And by performing immunoglobulins on a subset, or indeed all of these primary care patients, we can reduce diagnostic delay for these patients. So this is what we do effectively. We have a cutoff based on 0.5% of adult primary care. We use a cutoff in antenatal care that's 2 grams higher. We apply it to everybody of 8 years of age or older. For primary care and outpatients, we routinely cascade to immunoglobulins, but for inpatients, we review the results and make an individual decision on whether to add them or not. And when we review the results, we're effectively looking to see if they've had immunoglobulins or electrophoresis performed recently, and whether there's a potential cause for their low globulins that would explain them and mean that immunoglobulins would not be a useful addition. And we obviously look as well for suggestions of recurrent infection. And then at that point, we either add the immunoglobulins or alert the physician to the possibility of antibody deficiency. But in the vast majority of cases, we will actually add the immunoglobulins. It's also important to review your cutoff on a regular basis. So every year we do a quick review of our cutoff, because results do drift a little. And as I showed in one of my earlier slides, quite small changes can result in big differences to the cutoff. So this is actually my last slide now. I just wanted to very briefly say why I think it's important to use calculated globulins in a variety of different contexts. So the patient at the top here is the first patient we identified with CVID. And when I telephoned the result through to their primary care provider, they said to me, that explains why the patient has been on antibiotics for the last 18 months. But immunodeficiency hadn't been considered, and that's a very common scenario. And then this second patient is a patient who presented to our antenatal clinic and had hypertension and had the total protein albumin measured as a consequence of that. And when I spoke to her doctor, the doctor said there was no evidence of recurrent infection. And when we went to see the patient said she didn't have a problem with infections, but on closer questioning, it was clear that actually she had been coughing up green sputum for about 18 months. And she did have CVID, does have CVID. The third patient was another patient who presented with another unrelated cause and was identified as having CVID. The fourth patient is a patient who'd come back from Pakistan and had recurrent chest infections after their return, and they were referred for query TB. They decided they didn't have TB and would discharge the patient without doing immunoglobulins, but calculated globulin picked that up. And then the last patient is the patient who'd have several ICU intensive care admissions, but immunoglobulins had not been measured because it was felt that the patient's morbid obesity was the primary cause of their recurrent infections. Sorry, I just wanted to race through those just to express really this idea that there's a whole range of areas where patients may present with immunodeficiency in which immunodeficiency is not covered. So I'll finish there. I've just done a list of references there for the papers I've referred to, and I just thank you very much for listening to me.
Thank you both. Thank you, Professor Holding, and thank you both for sharing your knowledge and expertise with us. And now, I think you have said it all, to be frank, but now we will address some questions. And the first one I would like to ask you is about this method, because it is aimed at tackling late diagnosis, as you stated earlier in this talk. And as such, is it only for low and middle income countries, or do you think it addresses much broader the whole world or every country? What do you think about that? I don't know. I think both of you would have your answer because you come from two different continents. So maybe Professor Condino-Neto to begin with. We don't hear you.
I think no matter it is from a developing country or a rich country already developed, I think this technique is simple, cost-saving and life-saving for the entire of the world. So actually, the exams are actually old. They already existed for decades. And our mission here as medical educators and patient associations is to disseminate the knowledge to make doctors and nurses and other health professionals to be aware that this simple test can prompt confirmation and detect earlier antibody defects. And antibody defects are the most frequent kind of immunodeficiency, either primary or secondary. We have to remember that immunoglobulins replacement therapy are a product derived from plasma protein fractionation. So it is very simple. It's just to go to the array. So we use a simple assay on protein plasma, and we look there, and perhaps, well, apparently this patient may have a problem on antibodies, and then we finish the investigation. That's it. So it is useful for everybody.
Okay, thank you. Is there any comment on your side, Professor Holding?
Yeah, I think it has a universal application, because the big problem with antibody deficiency is not that it's difficult to diagnose, or difficult to test for. It's that doing the test is not considered, because antibody deficiency is not considered by the healthcare, the people looking after the patient. And so I think anything that we can do to alert a doctor to the fact that the patient might have antibody deficiency can do something about that 4, 5, 6 year diagnostic delay that we're seeing for these patients, and improve their quality of life dramatically by doing a very simple and very cheap blood test.
Yeah, thank you for that. We have a question about the test, the screening. Is it realistic and useful to include calculated screening into standard pediatric checkups, e.g. at 2, 4, 8 years of age? What do you think about that?
I agree. We should introduce that for the pediatric practice. Actually, we already do it. What we don't do is to pay attention on the gamma globulin fraction and perhaps think about an immunodeficiency. So everything is set up, everything exists, is just to remind doctors that that may be a very useful marker.
But Professor Holding, what about systematic screening? Is that realistic, in your opinion?
Well, the difficulty with screening and actually getting patients to come in and have a screen is you for antibody deficiency, because it develops so quickly, it seems, you'd have to do it almost every year, really, and I don't think that's realistic. But because patients who are suffering recurrent infections or indeed have antibody deficiency, primary or secondary, because they're having multiple healthcare encounters and multiple blood tests, then I think there's a real opportunity to use that episode to screen the patient. Of course, screening the patient for the doctor requires thinking about whether they have antibody deficiency, but in the laboratory, we can take that out of their hands and provide an opportunistic assessment of whether we think the patient has antibody deficiency. So effectively, we screen them every time they pass through our doors.
Okay, thank you. We have 3 other questions I would like you to answer, if possible. And there is one, I think you touched upon it a little bit, but can we get accurate data only once measurement? Or do we need to repeat measurements to get accurate results? If so, what should be checked within a certain time? What do you think? Maybe Professor Holding to begin with?
I think what's being asked is, if you get a low calculated globulin, should you do another one before you move on? Well, certainly calculated globulins won't replace immunoglobulins, and you must do the immunoglobulin test. One of the big issues with calculated globulins, and one of the reasons why sensitivity is probably only about 60 or 70%, is if a patient has an infection, they're producing lots of acute phase proteins, so the calculated globulin rises. So in patients presenting with infection, they may often have normal calculated globulins, even though they are hypogamma. So I would say that because our sensitivity is only about 60 or 70%, if you have a low calculated globulin in a patient in which there's no particular reason to think that they should have, then you should go on and do the immunoglobulins, or at least raise the issue with their doctor so that they can ask questions about recurrent infection and so on.
Okay, thank you very much. Another question, does the immunologist decide when to check immunoglobulins, or is that the GP prompted to request immunoglobulins if the calculated globulin is low? Professor Antonio, Condino, maybe?
I think once you have a cutoff level, if you have a calculated globulin or direct globulin under a cutoff level, then you should check on immunoglobulin dosage.
Mm-hmm.
Especially if the patient has any clinical picture of recurrent infections, or may have a profile for a primary or secondary immunodeficiency. So you have a cutoff, and that will prompt you to go further and do IgG, IgA, IgM.
Okay, thank you very much. And we have a last question from a doctor we well know from Sudan. What are the perspectives of including calculated globulin within new guidelines for PID screening? Of course, this is a broad question, but I would like to hear you about that. Maybe Professor Halsey?
Well, that's a very good question. The issue with screening for hypogamma is, again, this problem that it develops over a relatively short period at almost any age, if we're talking about CVID. And obviously that's different for X-linked agammaglobulinemia and some of those related disorders where patients will present in childhood, and being genetic disorders, they are susceptible to screening programs. But it'd be quite difficult, I think, to design a cost-effective screening program for adults for CVID and those related disorders. And so I think that the number of potential ways of tackling that, increased awareness, education of both healthcare professionals and patients, and the use of opportunistic testing when patients present for whatever other reason they might.
Thank you. And Professor Condino-Neto from Latin America, how do you see that?
Well, this is a very useful tool. I'll tell you that making like a mass screening with electrophoresis, I don't think that's going to be possible because of the high cost. The population is too big.
Of course.
What I would say is we have to work on big labs, big diagnostic labs for general purposes. And you see, all of the lab equipment nowadays, most of them come from a few industries, are very well-known brands. So what we could do is to set up an alert, a kind of signal, calibrate those equipment that each time protein electrophoresis is made and the globulin fraction remains under a cutoff value, that equipment should automatically prompt a message for the clinical pathologist or the biochemist to perhaps tell the doctor or gives a message, but listen, this patient may have hypogamma. So please consider to perform IgA, IgG, IgM according to the clinical picture.
Okay.
So that we could do is just to calibrate the equipment to prompt a kind of automatic message for further check.
Further check. Okay. So I think that we come to the end of this session, and I once again would like to thank you both for your insights and all the knowledge you shared, which was made possible thanks to a kind donation from CSL Behring. So thank you once again. On behalf of IPOPI, I would like to say a warm thank you to Professor Antônio, Condino-Neto, and to Professor Stephen Holding for this excellent session and for all the answers you provided. I think it was really useful. If we did not have time to answer all your questions, you will be pleased to know we will be sending you the answer by email. And thanks again to all for attending this IPOPI webinar. If you have a minute to spare, please share your feedback on this webinar by pressing the link shared on the screen. The link will also be posted in the chat. And please note that you will be able to see the recording on IPOPI TV within a couple of days. We encourage you to share it as much as you can to those who you think would benefit from it. Sorry. See you next time and keep safe. Bye-bye.
Thank you.
And thank you very much.